Thank you, sir. Thank the judges and all the presenters. Now we move on to the first session of the day. The session is a panel discussion on dyslipidemia management. May I request SS Lakshmanan sir to the stage, and the other participants, Dr. Anbuchelvan, Dr. Venkatesh, Dr. N. Kannan, Dr. Ashok Ranjit, to the stage.
I am Dr. S.S. Lakshmanan, and my panelists are here. Dr. Anbuselvan, you can raise a hand. Dr. Venkatesan, yeah, please come. Dr. Kannan,
Sir.
yeah. Ashok Ranjit. It's a panel discussion. Last about 5 minutes will be allotted for the interactive session. You can ask questions to the both chairperson as well as to the moderator as well as to the panelist.
Sir, here.
Quiet, please. Excuse me, please. Yeah, dyslipidemia is a big concern, especially for the diabetic population. And a lot of controversies now coming. People say you treat cholesterol, not to treat cholesterol. And we'll start with the first question to Dr. Anbuselvan. Can we use statins for all diabetics? We'll start with the very big controversial question.
Good morning, Lakshman sir, and good morning everyone present over here. Diabetes itself is a coronary equivalent. So the guidelines are very clear that how to prescribe statin. And before going into that, it is a progressive disease. We have to annually do all the regular checkups, and we have to identify the comorbidities. Depending on the comorbidities only, we are going to start the statins.
So you don't give statins for all diabetics?
So I'm coming to that, sir. If the patient is in the age group of 40 to 75, the diabetic, without any atherosclerotic heart disease, then we can start moderate intensity statin. And from age group of 20 to 39, if they have any one risk factor of ASCVD, we can start them on moderate intensity statin. The same 40 to 75 age group, with any one risk factor, we can go for high intensity statin. And with multiple risk factors, the 40 to 75 age group, we can go for high intensity statin. Along with, to reach the goal, if you're not reaching the goal, we can go for add with the ezetimibe and PCSK9 inhibitors. If the patient is above 75, we can continue the statin what he is already taking. If need to increase, not reaching the goal, if you need to increase the dose, then we can give the maximum tolerable dose to keep the target on range.
Yeah, I think this came from the study called CORD study, when they used 10 mg of atorvastatin in people with diabetes, new to the diabetes. They found 57% reduction on the coronary risk factors. This was done in UK. So all the Western guidelines will say from 40 to 70, give all diabetics statin. Depends on the ASCVD risk factor. No ASCVD risk factor, moderate intensity, as he rightly said. When they have a higher ASCVD, then go according to the severity and then start giving moderate to high intensity statins. But the LDL level is in diabetic is 100, not 130. But last week I had a session from Dr. Our Lai group. He always says that we have diabetes right from 15 to 10 years before the Westerners. So what he says is we have to give all our diabetics, Indian diabetics, statin. So if somebody asks you what is the proof, we can always say CORD study. And the next question follows like this. What are the contraindications for statin therapy?
Pregnancy is definitely a contraindication, and acute liver failure, and 5-fold increase in transaminase level, and CKD 4 and 5 stages. There is a controversy. It can be given, cannot be given, like that. But as of now, if the patient is on statin, just we can continue. Depending on the comorbidities, we can decide on that, sir. And fibromyalgia, that high statin intolerance, we can reduce the dose or we can stop the dose, depending on the clinical situation.
Yeah, there are some guys who, right from the beginning, they'll say, no, they will not accept statin, it causes diabetes. So there are cranky fellows are like that. So in them also, we can't force them statins. Thank you, doctor. And the next question goes to Dr. Venkatesan. What is primary and secondary dyslipidemia? And what are the LDL targets as per the LAI guidelines?
Thank you, sir. Based on the etiology, dyslipidemia can be classified into primary and secondary. As we all know, the primary dyslipidemia is caused by the genetic mutation in the lipid metabolism that elevates the LDL level, thereby causing the atherosclerosis and premature cardiovascular diseases. So it can be inherited as an autosomal dominant, autosomal recessive, and X-linked inheritance. And some examples of the primary dyslipidemia are familial hypercholesterolemia, familial hypertriglyceridemia, and dysbeta lipoproteinemia, and familial combined hyperlipidemia. The prevalence of familial hypercholesterolemia is increasing, and also ethnicity variation is also there. Coming to the secondary dyslipidemia, it is caused by the dietary factors or lifestyle factors and also associated with other underlying medical conditions. The risk factors are the physical inactivity, obesity, and then diabetes itself, hypothyroid, chronic kidney diseases and nephrotic syndrome, alcohol disease and chronic alcohol intake, liver disease, smoking. Everything are the risk factors that causes the secondary dyslipidemia. So these are the primary and secondary. Secondary dyslipidemia is common. We have to correct both the underlying condition as well as the lifestyle modification for secondary dyslipidemia. Coming to the Lipid Association of India guidelines, this is a simple and crisp and clear, and it is simple for the practitioners. Why? Because means it assesses the lifetime ASCVD risk for the our Indian phenotypic patients. We can categorize them as a low risk, moderate risk, high risk, very high risk, and then extreme risk. We can categorize them, our people, as a low risk, and then like that with some ASCVD factors. Major ASCVD factors are the age, which is a non-modifiable risk factor, that is more than 45 in males and more than 55 in females. And smoking, high BP, and low HDL level. These four are the three major risk factors for the ASCVD process. And along with that, high risk, other risk factors like high blood glucose level, lipoproteinemia, everything. So by this, they are categorizing as the low risk. Low risk means 0 to 1 major risk factors. Along with that, LDL levels of 100 to 129, like that. For that, the target LDL level should be less than 100. For the moderate risk patients who are having 0 to 1 ASCVD risk, along with that, LDL is almost 130 to 159, like that. For that, we have to keep them as LDL target is less than 100. Optimal will be less than 70 for those patients. High risk patients, that high risk category, diabetes itself as a disease itself, label them as a high risk category, and also major more than 2 major ASCVD factors. These patients, we have to keep the LDL target less than 70. Very high risk patients, who are all the very high risk patients, means diabetes with end organ damage, and with more than 3 atherosclerotic ASCVD factors, and also coronary artery calcium levels of from 100 to 300. For those patients, we have to keep the lipid target LDL level should be less than 50. For the diabetes with target organ damage, that is LDL less than 50, they are suggesting. For the extreme risk patients, that is extreme risk patient, they have also further categorized them as an A, B, and C. That is that recurrent ACS patient, heterozygous familial hypercholesterolemia patients, and familial homozygous familial hypercholesterolemia. For those patients, less than 30, less than 30 is the ideal target for that LDL patient. Even in the category C, they were further LDL less than 15 up to, they recommend up to less than 15 for a recurrent ACS patient, even with the LDL level of 30. That is the extreme risk patient with category C patient. For that, LDL less than 15 is the suggested target for those extreme risk patients.
Thank you, Venkatesan, for extensive elaborate. I think when the calcium score goes above 300, then becomes a very, very high risk.
Yes,
Cisco.
extreme risk.
People may ask, how can a patient live with a LDL of 30? Actually, we are born with 30. The newborn human being has got 30 LDL. And the secondary factor is some of the drugs also can increase your
Yes, sir.
lipemia. Before you start treating them, somebody's on steroids, somebody's on non-selective beta blockers, oral contraceptive pills, and especially the protease inhibitors. Now the ART therapy has shifted to integrase inhibitors. Olden days we used a lot of protease inhibitors. They have a very, very high lipid, especially triglyceride levels. Thank you, Venkatesan, for a very nice answer. And the next question goes to Dr. Kannan. Kannan, what is residual CVD risk? And how do you manage residual CVD risk?
Thank you very much, sir, for the great opportunity. First of all, dear friends, this question is very, very important, which is highly pertinent to our clinical practice. Because if you see any dyslipidemic patient or any diabetes and dyslipidemic patient, our aim and objective and goal will be to prevent the atherosclerotic cardiovascular diseases. In our clinical practice, we will be focusing to LDL less than 70 as a part of primary prevention or high-risk population. But recently, our own Lipid Association of India, which is leading by Professor SSL and Professor SN, even the patient with extreme high-risk population, those who are already having the clinical impact of atherosclerotic cardiovascular diseases, targeting the LDL less than 30 is ideal goal. But there are certain data. Even with the targeting the LDL less than 30, there is residual risk of once again going for the ASCVD risk by more than 14.4%. Because LDL alone will not be helpful in including the criteria in preventing the atherosclerotic cardiovascular diseases, especially among the diabetic population. Because most of the diabetic population, the LDL will be normal. That is low density lipoprotein. But we have to check the other important lipid parameters. We have to go for the TGL parameter, we have to see. And more than that, we have to see the LDL remnants like a small LDL particles and also lipoprotein A or non-HDL. So these are the important criteria that we want to implicate in our clinical practice to prevent the vast impact on to prevent the complication among the patient with the extreme high-risk population, which is already guided by the Lipid Association of India to have the LDL less than 30. For concentrate over the small lipoprotein A than ApoB, because ApoB is a carrier protein of the this one LDL particles. So these are the area we want to consider. We want to prevent the patient, give the effective quality of life and outcome. Thank you, sir.
Thank you, Kannan. I think it is defined as in a statin-treated patient, persistent atherogenic dyslipidemia denotes the patient has got a residual CVD risk. How do you make a diagnosis? Your almost LDL levels are normal, but when you check the fasting triglycerides, when you check the fasting HDL levels, the HDL levels tend to be very, very low, and the TGL levels goes high. So these guys needs intensification of the treatment. Probably they need a more diet advice. Maybe if they are not on correct dose of statins, we have to add a correct dose of statins. In fact, the Lipid Association of India has given high risk people with a C, where they have still a residual risk, people add anti-inflammatory drugs like colchicine to the society. Thank you, Kannan, for a very good prompt answer.
Thank you, sir.
Next question goes to Dr. Ashok Ranjit. What are non-HDL cholesterol? What are remnant cholesterol? What is lipoprotein little a? And what are their importances? Very good question. Please answer.
Thank you, sir. Thank you for the question. All these years, our lipid management is based on, or it is always circling around the LDL cholesterol particles. But as sir said, no, like even after bringing down the LDL cholesterol to the target level, whatever the target we fix for that particular group of patients, there is a residual risk of CVD events. So where we are missing, what we are missing. So what can be the alternative? What can be the better predictors? So there comes the role of these other parameters. That is, one is non-HDL cholesterol, where we calculate this value by reducing or subtracting HDL cholesterol from the total cholesterol levels. So which includes, which also gives an account, takes an account of other lipid particles, other triglyceride containing, chylomicron containing lipid particles like VLDL, IDL. So these particles also have a, play an important role in developing cardiovascular events. So this is a better predictor, better parameter for assessing the residual cardiovascular risk. And the remnant cholesterol, again, the remnant cholesterol, it speaks about the combined VLDL and IDL, which are triglyceride-rich cholesterol LDL particles, lipoprotein particles, like which again, like when it is high, when it is, a study shows when it is more than 30 milligram per deciliter, almost 40 to 50% increase in cardiovascular events and events of stroke. So this remnant cholesterol particle is a better predictor than the LDL cholesterol in predicting the residual risk of cardiovascular events. And again, apolipoprotein A. Apolipoprotein A is the carrier of HDL particles, cholesterol particles. So measuring this can predict the risk of, again, the cardiovascular events. It is also a better predictor than the LDL cholesterol particles. If it is more than 65 to 130 milligram per deciliter, it is considered to be safe. If it is lesser than that value, like it is considered, they're considered to be an increased risk of residual coronary vascular events.
Thank you, doctor. I think the definition of remnant cholesterol is this. You have to minus from your total cholesterol both HDL and LDL cholesterol. LDL cholesterol minus HDL cholesterol minus LDL cholesterol, then it becomes the remnant cholesterol. You should be normally less than 20 milligrams, 24 milligrams. If anything more than 24 milligrams, then you have to be worried about, because there may be some evidence of your raised VLDL and the triglyceride levels. Again, the diet modification. I think very healthy lifestyle modification is very important. Non-HDL cholesterol is almost equal to ApoB, because we remove the good cholesterol from the total cholesterol. So non-HDL represents exactly ApoB, poor man's ApoB. So in India, we still practice non-HDL cholesterol. We keep a target quite a tight. People say 130, now it has come to 100. LPA again is again a form of LDLC. It is a very, very, very bad protein because it causes premature coronary artery disease. See, ENAS and ENAS has done a lot of studies in immigrant Indians in US, UK, Singapore, where they found the premature coronary artery disease, myocardial infarction in Indians occurs because of high LPA. Right now we have only drugs like just PCKS, PCSK9 inhibitors act a bit on LPA levels, but there's a drug called pelacarsen. They probably may come to the market in few months' time to probably reduce the LPA levels, going to be approved, and quite a few drugs are on the pipeline. They're all antisense oligonucleotides. Thank you, Dr. Ranjit, for a good answer. We'll come to the next question to Dr. Anbusalam again. What is the normal triglyceride levels? One of the very, very big sin in Indians. We all have high triglycerides. And what are primary and secondary hypertriglyceridemias?
Thanks again for the question, sir. The normal TGL levels is 150 milligram per deciliter. Previously it was 165. We are dividing triglyceridemia into two, primary and secondary. Whenever we are unable to find any secondary cause for any triglyceridemia, then we can come to the conclusion of, if you are properly evaluated, then we can come to the conclusion of primary hypertriglyceridemia. In assessing primary triglyceridemia clinically, first thing we have to assess what is the level of triglyceride, isolated triglyceride levels. Second, very thorough clinical history. So we have to look for any family history of pancreatitis, family history of atherosclerotic cardiovascular disease, and some other parameters we have to see. And physically we can look for the xanthelasma. And these things will make us close to the primary hypertriglyceridemia. Secondary, we know whatever Venkatesh told, so many comorbid conditions which can increase the triglyceride levels, drugs, diseases, and so on. And when you look at the picture, if the triglyceride elevated more than 500, we have to target triglyceride, or we have to target the secondary causes which can elevate the triglyceride. If you first correct the secondary causes, automatically the triglyceride will come down, like diabetes and drugs. We can reduce the dose of steroids and other drugs. When it is less than 500, our focus should be on LDL cholesterol. This is how we are approaching the triglyceride. And in primary hypertriglyceridemia, isolated triglyceride, there is a possibility of hyperchylomicronemia, familial hypertriglyceridemia. When triglyceride elevated and equally total cholesterol elevated, there is a different familial combined hypertriglyceridemia conditions are coming. This is from my side.
I think it's a perfect answer. When you have a TGL more than 1000, we are very sure that patient has got a familial chylomicronemia syndrome, 1000. That's the only condition where you get the more than 500, the people are prone for pancreatitis. I say when they are less than 500, then please think of all these secondary causes. There are a number of secondary causes, right from your diabetes, obesity, hypothyroidism, CKD, binge alcohol drinking. Number of drugs can cause. Even the autoimmune disease like SLE, RA, all, if you could try to treat all those secondary conditions before you start treating the patients with the triglycerides. I think the wonderful trial, we have a trial called the Reduce It trial, where they use the drug called isocopentyl ethyl in 4 grams a day. I started using it now. We get an excellent result. We get a 54% reduction on the triglyceride levels. I think it's a big boon to the thing. And we had the omega-3 fatty acids. The subfraction is the EPA, which has been used in the Reduce It trial. Thank you, doctor. We'll go to the question again to Dr. Venkatesh. Name all non-statin drugs available for dyslipidemia and what are the favorable combinations with statins. Make it very brief.
Okay, sir. Many drugs are emerging for the management of the dyslipidemia, but statin still holds good and occupies a significant position in the management of the dyslipidemia. Non-statin dyslipidemic drugs may be useful in statin intolerant patient, mixed dyslipidemic patient, and also patient not achieved the LDL target even after maximized the dose of statin, even after using the maximized dose of statin, still not achieved the LDL target. We can use the non-statin dyslipidemic drugs. The available drugs are the first one is the fibrates. Fibrates are the drugs which reduces, it is a PPAR gamma agonist. It reduces the triglyceride level. It is one of the most common combination with the statins for the diabetic dyslipidemia also. So, and it is having multiple interactions also with the drugs like warfarin, like that. So, one of the common association with the statin is the fibrates, and fenofibrate is the available drug as of now. And next one is the niacin. Niacin not in clinical use now at present, but it is the only drug that significantly increases the HDL level. Its derivatives are in the pipeline. And another next one is that bile acid sequestrants. They are not used routine for the clinical use, but still it is because of its poor tolerance, but it is the only drug that can be used safely in pregnancy for in case of homozygous familial hypercholesterolemia or familial other primary lipidemic patients also we can use this bile acid sequestrants. And other drugs like ezetimibe, which is one of the drug which reduces the LDL cholesterol absorption, which creating a impact of 30% reduction in the LDL level. It is also one of the commonest co-prescribed with the statin. If not, we can not achieve the target of LDL levels. Ezetimibe, and then is the next one is the newer molecule is the bempedoic acid. Bempedoic acid is then it's a pro-drug which is converted into the bempedoyl CoA. It also upregulates the LDL receptor, thereby it increases the intake of LDL, thereby it having a very good reduction in the LDL level. And also it is also co-prescribed with the statins with no interactions. And other drugs like PCSK, the newer drug is the PCSK9 inhibitor, which is a monoclonal antibodies, that is evolocumab and alirocumab. And after that inclisiran is also there. Inclisiran is an double-stranded long-acting small interferon or RNA that also inhibits the PCSK inhibitor, which is an injectable drug. It is a injectable drug.
Just name them, doctors to talk about each
okay, sir.
Just name.
Just okay. And also the icosapent-ethyl is also one of the drug which reduces the triglyceride level. These are the available drugs, and also lomipetide and mipomycin are the available drugs for the homozygous hypercholesterolemia.
Thank you, doctor. I think when you use statin plus fibrates, good combination, but one should be cautious when you use a rosuvastatin with a fenofibrate. The one causes severe muscle toxicity. That's number one. Otherwise, the US has given a clean chit, combination of statin, ezetimibe, statin plus pemvidinic acid, combination of statin, ezetimibe, pemvidinic acid, ahead of statin plus PCSK9 inhibitors. We can also use statin PCSK9 inhibitors. We can also use statin inclisiran. I think the number of drugs are going in the pipeline, increasing our the value of LD reduction great extent. I think next question will be, doctors will briefly say about each molecule. Dr. Kannan, please say about a few words about ezetimibe and the pemvidinic acid.
Thank you, sir. So, friends, these both the compounds, ezetimibe and bembudienic acid, is a very unique compound, but it's very soundless. There are multiple data with this, especially ezetimibe. So, whatever may be the metabolic dysregulation like ABCD, DBCD, or CMBCD, adiposopathy is the main culprit. This molecule, ezetimibe, doesn't have any impact on the adipose tissue, but these are unique mode of action, acts on the small intestine. If you see the action of ezetimibe, it inhibits the cholesterol absorption from the small intestine, and therefore the disposal of cholesterol to the liver will be mitigated. That is, converting to TGL and thereby producing the VLDL and ELDL can be minimized. And therefore, this molecule plays an important role in the dyslipidemia patient. Those the patient who couldn't able to tolerate the statin to the high dosage, and also those the patient rightly said by Venkatesh that even though with the high dose of statin, that they couldn't able to achieve the goal of statin less than 70, less than 55, less than 30, which was recommended by our own LAI. So these molecules, on combination with the statin, have been clearly proved in this enhanced trial, and also we have improved trial. These both the trial have the specific action not only on reducing LDL by means of statin, but over than that, it has the property reducing CRP also, and also in enhanced trial, it has the property reducing this carotid intermediate thickness. So any patient with esteemed high-risk populations, so any patient with statin intolerance, so any patient with a high dose of statin couldn't able to control the LDL more than 50% or having the goal less than 30, maybe we can focus this molecule. Regarding the bembudienic acid is unique because this acts as the pathway of cholesterol synthesis. We know that HMC reductase inhibitors, we know that reductase enzyme inhibition, but this molecule, bembudienic acid, it acts as an ATP citrate lyase inhibitor because this makes the inhibition of conversion to citrate to the saturate CoA in the process of the lipid oxidation and converting into cholesterol. So this also having important premium landmark trial as a clear data. Clear data shows the importance of, along with the statin, allow the low dose of statin, or a maximum dose of statin, who couldn't able to tolerate the statin with the muscle intolerance also. These molecules, in combination with the statin or non-statin, have the specific outcome on atherosclerotic cardiovascular diseases to almost 16% to 18%, have been clearly proved by the clear trial, and have been approved by our own lipid association, which is guided by Professor SSL and Professor SSL.
Thank you, Kannan. I think when ezetimibe launched in 2004 in India, every stall you enter, 10 plus 10 is equal to 80. 10 atorvastatin plus 10 ezetimibe is equal to 80 milligrams atorvastatin. We make a big fun. What evidence you have to make such a big statement. But the statement has been changed by a trial called Reduce It trial. Improve It trial. Improve It trial. When they used very poor simvastatin with ezetimibe, the reduction of the LDL and the CV protection was excellent in all post-ACS patients. That brought back our ezetimibe back to the limelight. I think you have to say hats off to the Improve It trial. Now, I think people started using, even like you use combined therapy in hypertension, 2 drugs. I always use, in my patients of diabetes, I always use 2 drugs in a combination of atorvastatin 10 mg plus ezetimibe. I've seen very good results. My personal experience, I think it actually acts on a receptor called the Niemann-Pick C1-like receptor in the gut, where it blocks the reabsorption of cholesterol into the circulation. Thank you, Kannan. Pemvidinic acid, again, now is plenty of studies. We have the clear studies, the clear harmony, then we have the clear, all these studies have shown that it's got an excellent compatibility with the statin. So pemvidinic acid alone can be given, or people also can combine statin plus pemvidinic acid, statin plus pemvidinic acid plus ezetimibe. I think we have 3 drugs combinations, first time approved in FDA as a fixed drug combinations. I think the next question goes to Dr. Ranjit, say something about PCSK9 inhibitors. The hard drugs now. Yeah.
Yeah. PCSK9 is a protein which inhibits that LDL receptor which is present in the liver. That receptor helps in removing the LDL particles from the circulation. So this PCSK9 protein that tends to inhibit that receptor, thereby reducing the ability of the liver to clear the LDL particles from the circulation, thereby increasing the LDL levels in the circulation. So this drug PCSK9 inhibitors, this is a protein, this is an antibody to that particular protein, thereby preventing it from binding to that LDL receptor and blocking the liver's ability to uptake the LDL cholesterol. So thereby blocking that particular protein, the ability of the liver in clearing the LDL particles from the circulation goes up. Thereby we can bring down the circulating LDL cholesterol level, thereby bringing the cardiovascular risk. But the thing is, since it's a protein, it's available in injection form and it's a costly drug. So we can use but in certain indications like some familial dyslipidemias, where the target level is not achieved by maximum dose of statins, or when there is intolerance to statins, we can use this drug, or it can be used along with statins when the target is not achieved as well.
Yeah, this has become a fourth line drug. After statin, estimable, pemvidec acid, still the patient do not have the target, then you can use this PCSK9. As he rightly said, it's an injection form. It downregulates the LDL receptors. So once you block them, the receptors come to the liver site in a huge number. So the LDL absorption will be much faster. Clearance will be very good by the liver. I think it's given as a twice monthly or once monthly injections. We have quite a few drugs in India also. Alirocumab and evolocumab. Repatha is an injection. Still, it's expensive. I used it in about 2 to 3 patients of mine. I think we'll come to the question, the last but one question, question about the inclisiran. Inclisiran is going to be by Dr. Anbuzselvan. Make it very, very brief.
So as Rajit told, it is it's a PCSK9 inhibitor. It increases the more LDL receptors. It is available in injectable forms. It can be given, there was a trial where they given at the 0 dose, 90 days and 180 days and 6 months thereafter. So only 4 doses were given. We have data for only 2 years. So we need to wait for safety data and other data. That is about inclisiran. So the injectable cost is very high, more than these already existing antibodies.
Yeah, actually it's called a silencing drug. It silences the RNA of the PCSK9. So when it goes and interferes with the manufacturing of the PCSK9, the primary target, it just has given as a once in 6 months injections, and the trial like the Orion 1 and Orion 3 have really shown that the drug is really have very least side effects. So just forget about it. First dose may have to be in 1 dose. After 3 months, later on, just once in 6 months' time. I think time has to say in India, I think India it has come. I think the MRP is something like 1,05,000 rupees for one injection. I think the final question will be to the hereditary familial dyslipidemia, screening, clinical features management. Make it one line, Venkatesan. Already you alluded to.
Okay, sir.
Yeah. I extend for 5 more minutes time. Yeah.
Hereditary familial dyslipidemia. The screening is, the first is that elevated LDL level more than 190 and a non-HDL level more than 220. You have to screen for the familial dyslipidemia, and also physical signs like tendon xanthoma, tuberous xanthoma, xanthelasma, arcus corneus. For if the patient having the findings, we have to we must rule out that familial hyperlipidemia, and also in the young age definitely we have to rule out, and the family history of premature cardiovascular disease, family history of early atherosclerosis, everything means we have to rule out. The screening is needed. Coming to the diagnosis, the same thing, but definitive diagnosis is made by the genetic gene studies also must be there. Then many criteria are there. MedPet criteria, Simon Broom criteria, and the Dutch criteria is there for the diagnosis of the familial hyperlipidemia. Coming to the management, these pharmacotherapies, along with these pharmacotherapies, plasma LDL apheresis in case of homozygous dyslipidemia, and also liver transplantation is the final option for the severe homozygous hyperlipidemia. Thank you.
These patients, the screening has to be done as early as 8 to 10 years. That's a very important home message. Somebody on a routine checkup, LDL more than 190, suspect the familial dyslipidemia. They have markers, it is homozygous. No markers, it is heterozygous. They have a arcus senilis, that's of the upper cornea. Again, please suspect the patient's got a hereditary. Number of drugs is coming. I think we have one drug called lopitapide. I think probably it may be.
Lopitapide and myposaran.
There are drugs available, but still we have very not having an effective control on this dyslipidemia. I think last final question to Dr. Kannan, say something about tirzepatide.
So even though the progress of modern sciences, GLP-1 plays an important role in managing both diabetes and obesity. This tirzepatide recently Finan coined as twincretins because this acts both on GLP and GIP. So not only to overcome the this one glucophenotype, but regarding with the obesity management, it is able to control the weight by more than 20 kilograms. That has been already proved by SURPASS trial and as well as SURMOUNT trial. SURPASS trial mainly for the diabetic patients, SURMOUNT mainly for the obesity patients. So this molecule addresses a glucose control, obesity, this one lipid mechanism, decreases the fasting triglyceridemia, and therefore this molecule wonders among the diabetic populations to give the quality of life and outcome.
Yeah, all my diabetic friends from US, they say it's a beautiful molecule. The weight reduction is so good. Tirzepatide probably it may come another 4 to 5 months in the Indian market. Again, injectable thing. I think we have finished up our dyslipidemia lecture. Any questions from the floor? Few questions are allowed. Yeah. Mike could up. I do not know how much I covered. I tried to cover all aspects of
Yeah, you have covered very well, sir.
dyslipidemia.
And we have discussed the real science also. I have to thank you and thank the panelists also. They have updated everything about dyslipidemia and all the newer drugs. But for delicates, if they properly adopt the diet advice, exercise, and the basic drugs like your statin, whether it is atorvastatin, simvastatin, or rosuvastatin, along with ezetimibe and fenofibrate, beautifully controlling even 100% of our diabetic patients or even hyperlipidemic patients. These drugs may be rarely useful. For scientific aspect, scientific forum, we can discuss, but they are all costly. But I compare like this. Americans, they eat everything, they discover new drugs. See, each dose cost about 1.6 lakhs means how can we afford? But if you avoid certain oily diet or some fatty diet, do some exercise, statins, ezetimibe, and fenofibric acid, these three are, see, I am in practice for more than 40 years. So all my diabetic patients are beautifully maintained, all lipid profile, and all your hypothyroidism patients. So these drugs may be rarely used, if at all, if it comes.
40 to 45% respond to these basic drugs. Rest will.
I could
because
say 90%.
we don't know for the
I could
residual
say
CVD risk.
90%.
Yeah.
I could say 90%.
I think. Any more questions from the audience? Yeah. He is a very conservative, optimistic physician, Dr. Panneerselvan.
I am also the same. Sir, few basic doubts. When you have TGL more than 1,000 in patients, familial, especially in low age, what complications we will expect in a patient? What we can advise?
So familial hypertriglyceridemia, more than 500, the acute
1,000.
complication is acute pancreatitis.
Yes, sir.
Very, very deadly, dreaded complications. Unlike biliary pancreatitis, unlike alcoholic pancreatitis, the hypertriglycemic pancreatitis is very worse. I have very, very bitter experiences. We have no drug to reduce 500 to 250 in one single day. It's not possible at all. The damage occurs continuously. The sphincter of Oddi spasm goes on. Later on, it also adds on to your excess VLDL, IDL. So your atherogenesis also is enhanced by high triglyceride levels.
Will it has more adverse effect on coronary artery disease?
Definitely, yes. That's what we are talking about
Something
now.
like acute infarct. It
See-
can happen. And regarding bempedoic acid, recently the markets are not, pharmaceutical companies are not promoting it as it was, though the evidence is good. Is it so?
For?
Any problem bempedoic acid, sir?
Pemetrexed is a very good drug. It's a very good drug, but not alone drug.
Yes.
As alone drug, it may not be so effective. If you could combine with the statin, it is good.
Yeah, that's what we are using. We have good evidence. The companies which promote the bempedoic acid, now slowly one by one, it's not available in my place. Is it so here?
It's available very freely.
Available.
Yeah.
Okay, sir. And regarding, last question, sir. Regarding the measurement of lipids in routine, some labs do the direct HDL measurement, some labs calculate. And second doubt, when you do triglycerides in a postprandial stage, is there a difference?
Yeah, there'll be always 30 to 40 milligram higher.
But practically it will not affect.
Yeah.
Regarding the calculated HDL and the direct measurement,
Direct measurement is always better.
always better. Thank you, sir.
Just one comment. So, you have many diabetic patients who have more advanced stages of kidney disease. So the EGFR might be 3B and less. There, if they have hypertriglyceridemia, many a times fenofibrate cannot be given. We know that there might be a further decline. So such cases, saroglitazar, because it's not eliminated to the renal route, is a good option. And also you have better glycemic control.
Yeah, we can use both the omega-3 fatty acids, like the fraction of that, the icosapentael ethyl, in CKD patients. Don't use fenofibrate in patients who got a declining CKD. Very, very dangerous drug. They go for a lot of side effects. In fact, I slowly I've withdrawn my prescriptions for fenofibrate. Very, very toxic drug. So even slightly higher dose, the patient already prone for CKD, they again can worsen the CKD. As you rightly said, the TGL levels are the worrisome factor in patients who got a CKD.
Hypertriglyceridemia in diabetic patient is most probably due to poor glycemic control. So in such cases, diabetes control is more important, that too with the insulin. Insulin is the first drug which bring down the triglyceridemia.
Yeah, no need to treat secondary dyslipidemia, triglyceridemia, to treat the secondary cause. Treat the thyroid, treat the sugar, and the lifestyle modifications. When they stop the alcohol, they'll become all right. I think, thank you. Give a big hand to all the panelists. They are very young doctors, but they really did a very good homework. They brought all the message to the audience. Thank you, thank you. I individually thank all of you. Thank you very much. I'm always an examiner. Thank you, Viru.
Yeah, I request our moderator to present the memento to Dr. Venkatesh. To Dr. Kannan. That's Venkatesh. Then to Dr. Kannan. Dr. Anbuchelvan. Dr. Ashok Ranjit. Dr. Ashok Ranjit. And I request Dr. Paneer Selvam to present the memento to Dr. S.S. Lakshmana. Sir will give. So thanks a lot, Lakshmanan sir and all the panelists. With this, we end this very interesting session. Anyone who has more doubts can ask them personally. And we'll move on to our next session. Another interesting session